I just want to check online. Is the video and audio okay?
I see. Yeah.
Okay. Just give a minute for people to join. And could I just get some confirmation from people online? Are you able to hear us okay and see us okay?
You got a thumbs up from somebody.
Okay.
Yes.
Audio is good.
Okay, fantastic. Thank you. Okay, so we'll go ahead and get started. So thank you for coming to PCEP for April 2024. This is the second time we've attempted this hybrid format. We're at Station 151 in Ridgefield today. And so today I have a little bit of teaching on the back end, but the front half of the course is going to be an introduction to the CARES team and an explanation of what they do. And so with that, I've got Chief Jackson and then Sam Lewis from the CARES team to talk about their program.
Great. Thank you, Doctor. The CARES program, we're a little bit unique with Clark Tallops right now. We have the only program that's fire-based as far as co-response in Southwest Washington. We kind of started down the path in 2018, 2019, and there's been a lot of things that we've learned along the way, which really kind of led us to our current model where we're working towards kind of a county-wide model. The key part with that was a lot of our partnerships that we work with. So we're fortunate right now that we are pretty much 100% funded with outside sources. We get money from the Accountable Communities of Health, which are the folks responsible for Medicare and Medicaid transformation. We have a partnership with 3 different contracts for the Area Agency on Aging and Disabilities for Southwest Washington, otherwise called ADSWA. They give us money so we can address specific things around falls risk reduction, medication management, and transitional care services for folks leaving the hospitals. In addition to that, we have contracts with both hospitals for transitional care for folks that are a high likelihood of readmission. Those things all align well because they're really targeting the same clients that we're looking at as far as high system utilizers and folks that are putting an extra strain on the 911 system. So right now, we started with our program. We recently added a nurse that's funded for the initial 2 years through Swatch, but is employed by Camas-Washougal Fire. And then we are getting ready to add a 3rd care provider through Fire District 3 that'll be part of the team as well. There's a couple other grants that we have out there looking at a couple additional positions. Generally, a lot of the work is social work. We pair usually a paramedic with someone that's engaged with the social work side or helping to look at other things. Kind of a unique program as far as wraparound service. But that's a little bit on how we got here. I'll let Sam jump in and talk a little bit more about the program and how we function.
Yeah, I mean, it's a really good introduction to kind of what we have. And again, we'll go through kind of all the slides and sort of kind of the minutia of what we do and kind of the things that we're able to do contract wise, but really looking at it more of a holistic approach to kind of folks that, again, are calling 911 a lot, really where the hospital isn't the best bet for them because they're kind of going right home and you'll probably get called as soon as they get back. And or those folks that are just refusing all the time, but maybe needing lift assists as well as a variety of other things, or you go into a home and there's just so many issues going on where that moment in time is really not going to be able to be fixed. You really only have 2 options at that point. So we're trying to figure out those other things. So we'll go through kind of all the services we have, but I really want to, make it a discussion and any questions that come up, really kind of looking at it. Again, as we said before, our CARES resource, really, we have kind of the, your traditional emergency services where we work really closely with. We have an acute co-response behavioral health crisis co-response unit that's able to kind of run on acute calls with EMS crews and with fire crews. And then we have a referral follow-up program. So there's 2 different ones. You might have heard over the radio, CARES 21 get called. That is our acute co-response behavioral health co-response model. And our CARES 22, which is our follow-up model, that does a lot of kind of follow-up from all those contracts that were originally discussed by Chief Jackson. Really, when we're breaking it down, this is kind of what it looks like. Our referral sources come from multiple folks, from all our contracted sources, from our follow-up providers. And then even with our acute co-response, we work very closely with law enforcement as well as with the other partnering fire agencies currently right now. Again, looking at kind of how we're staffed right now, we do a community paramedic that's through CCFR. We have a community nurse through Camas-Washougal Fire. We have myself, social worker, and then we have an environmental fall risk reduction specialist that's able to do kind of quite a few things, and we'll kind of go into that a little bit. Right now, our follow-up model does not respond to emergency incidents. They're able to if needed and requested, just due to we have everything kind of staffed kind of with the community paramedic and an ALS vehicle. So they're able to, but we don't typically do that. We're really looking at follow-up with patients that need a longer-term medical support, social support, that behavioral health connection, fall prevention, and just maybe environmental risk. So you go in and the whole house is just a biohazard in itself. Looking at kind of what we can do for folks like that. Really, we're looking at reducing further emergencies and dependence on using 911 for any call that comes up for folks because they have no other resource and they have no other direction to go. We see a lot of folks call, not just for lift assist and so forth, but because they don't have a primary care provider, and you guys are the last resource they're calling because they know you'll show up and help them. So how can we do that? And again, providing really vulnerable individuals with connection to social, medical, environmental, all at one time. We're in the house, we're there, let's do what we can. We don't need to kind of work in one individual silo and then refer out to someone else to do that. We're able to go in and do it all ourselves if needed, if we're able to. Again, just a little reiteration of kind of what we just talked about, really kind of that dependence. And again, we are receiving referrals both from CTFR crews, Camas-Washougal crews currently, and through our contracted agencies such as ASWA, Legacy Salmon Creek, Peace Health, Swatch, and other local fire districts. We are working with Fire District 3 to start receiving referrals from them, hopefully shortly in the future, directly from their operation crews. We do it through a combination of both ESO, emails, sometimes a phone call, as well as a couple different ways that we're receiving referrals right now. Again, two of our big contracts, we do have contracts with Peace Health Southwest and Legacy Salmon Creek, the local area hospitals. One of the things we did initially is we started working with the hospitals for folks that are in our district for discharge help and assistance. We realized really quickly that hospitals don't know fire boundaries, fire districts, and actually don't care. So we were able to open it up to all of Clark County through both hospital referrals. Again, we receive contracted funds for both the referral aspect of it, so folks referring to us, as well as in the home visits and follow-up that we do with them. Because some folks take one follow-up visit post-hospital, some take 16. So it really goes to a lot of different ones. And again, these are all folks that are coming in, being discharged, that need more chronic disease management. They're at risk of rehospitalization for numerous reasons, including falls. They're being discharged with little to no social supports. It's unbelievable how many folks get discharged and really shouldn't have been, and usually end up going back to the hospital typically the next day or two. Those who need assist devices, installation of durable medical equipment, we're able to help folks with that. Especially, we find a lot of folks get discharged with anything from oxygen to Hoyer lifts or whatever and don't know how to use them, and they really should be using them. And again, we try to bridge that gap between discharge and maybe that medical follow-up, such as home health, PCP appointment, and so forth. We're really doing our best to see what we can do. We have a lot of folks that have not heard from their home health provider. We have home health that refuse to go into some homes for a variety of different reasons due to maybe the cleanliness of the home, maybe some difficult behaviors by the client themselves. So we look at how we can kind of really bridge that gap and try to get them to come in, even if we're going at the same time as a home health provider. We also work with the Area Agency on Aging and Disabilities of Southwest Washington, or ASWA, on transitional care services, which really directly ties into the hospital referrals. So again, these are for folks over 60 that have been in the hospital and are being discharged with no supports. So it's very similar to the hospital contract, but these are folks that are being really referred directly to the area agency because they need other help. They need in-home help. They need this, they need that. So we're able to go in and really work with the caseworker and care worker, depending on who it is, to see what the need is and how we can model and get them actual services directly right then and there. A lot of times we find some of the other agencies will make a call to someone, can't get a hold of them, maybe mail them some information and resources, and that's really it, which we've done too. We've called people multiple times and never heard from them. So we're really trying to even go out there, do a cold knock and see what's going on, because you get a really different view of someone once you actually see them in their home. For some of these other social agencies that really, can't get a hold of anybody. It's a volunteer program. There's no mandate that they have to work with us. But if we come knocking on your door, typically, as you guys know, they answer the door for you because the fire has a very, very strong trust with the community. So we're able to really kind of dive into that a little more. We also do a follow-up. It's an environmental risk reduction program. We call it FERP. Thanks to Captain Holman and his fun name for that. But really, there's two different things. We do fall prevention and home safety. And really what that's looking like is going in, addressing the home and addressing kind of any kind of fall needs. That's including installation of durable medical equipment, grab bars, what else? Everything. We've moved rugs, we moved furniture, we help someone, put stuff in a lower cabinet up to a middle cabinet because they're always falling while reaching over. We teach about fall safety, walking with, walkers, or, a lot of folks aren't ready to admit that they can't, they have to walk with a walker, so they're trying to still move without one. So we're really doing a lot of education and work with folks, especially around the aging process. Again, it's completely funded through ADSWA right now. Although the CARES program has multiple braided funding streams, this particular program is entirely funded by ADSWA, but we don't do it separately. The program works within all our CARES programming. So when we're going into a home, we're not just doing just a falls, we're doing everything that we're going to talk about kind of coming up. So fall prevention, patients over 65, falls that do not have to or do not appear to be a result of intoxication or acute illness, or like ice. When we had the big ice storm, we had a lot of falls. Again, we're not going to do a lot of fall prevention around it. We can, but some of those are one-offs. We're really looking at those impactful falls that we actually can address through multiple things. They might not have, folks that don't have a full-time paid caregiver, and they're not like in hospice or residential facility or adult living home. We can work with those at times, and we try not to, just because there's a lot of other supports that they have and a lot of programs and treatment plans they already have surrounded within those homes and so forth. And again, these are patients that can be feasibly contacted. We have folks that fall, let's say, even at the casino. They may fall outside of the casino for a variety of reasons. They may not be our typical fall client, just because usually there's a different reason they're falling outside of that kind of particular place. You can guess. We do our steady assessment. It is a CDC approved kind of assessment. Just a couple things that we can do with folks really to kind of see where they're at. We'll do this if they're able to, if they're willing to. Again, all this is a voluntary program. So when we go into someone's house, we try to do a whole assessment on them in a variety of different ways. And this is just one part that we can do. So I'm not going to read all of it to you. Home safety, we're already in someone's home, so why not do everything else that we can? We do fire safety, we check smoke alarms, install smoke alarms. We go over folks, what their need is in the home, especially if they're using heaters or if they have extreme clutter or have some hoarding type of behaviors. We'll see what we can do about, making sure stuff not on the stove and so forth. We do a lot of hazard mitigation with the patient's permission and supervision. Again, that's the installation of grab bars or other durable medical equipment. That's sometimes picking up a rug and moving it because they keep on tripping over it. It's moving furniture. I know our team has moved couches before for someone who needed it. It goes really of whatever we're seeing in the home that can really be helped in reducing any kind of injury that we can. We also do a lot of referral, follow-up, and advocacy, and I'll go over that in a little bit. I think it's after the next slide. We also do, which is a huge component, medication, education, and reconciliation. It's another grant that we have through the Area Agency on Aging. And really that's going in, reviewing medication delivery, how they're taking their doses. We come into some of these homes and they have all their meds in one big box, and you can't tell what's what. So typically we will have some of the hospital reports or doctor PCP reports of what meds they're supposed to be on, and we can review that with them and see what they're taking, what they're not taking, as well as if they are talking about why they don't take meds because they don't like the way they feel or it makes them feel this way, we can get hold of the doctor, the PCP, and kind of have that discussion where they can actually have more of a different discussion, because a lot of times our clients aren't telling their doctor they're not taking their meds. Usually they're just telling them, yeah, I'm taking them as prescribed, but they're not. And we can tell if they have a full bottle of one that they should have been already out of. We're able to ask them and really go over why aren't they taking it and really get to the nitty gritty of it. We do a lot of follow-up with primary care physicians to figure out kind of what meds they're supposed to be on, what they should be taking, why aren't they taking them. We also do a lot of emergency medical information posted on people's fridge. I don't know if you've seen them. You might have gone into homes where we have kind of our sheet with all their medical conditions, all their meds and their contact information that we're able to put on the fridge for folks, especially when EMS goes in, to really help them out and kind of do that process a little smoother. Our team has been able to really successfully organize and store medications for folks also. Again, we've walked in and people have had bags and bags of meds, old, new, all combined in one. Sometimes they're open. We've gone in and there's been, insulin packs all over the floor, and they're still taking them as they need. And so really being able to kind of go over what's going on with someone to help them reduce kind of the calling 911 for, things that can be preventable, especially with medication issues and so forth. And this could be really time consuming for our team. So again, sometimes our team is there for 45 minutes. Sometimes they're there for 3 hours with folks. They move it up to 4. Do a lot of hazard mitigation. We talked about the grab bars. We post EMS sheets. If they have a pulse form, we'll go over those, what those are. A lot of people do not have them or understand them. We'll try to put them in an area that they're able to do. We usually try to stick to a fridge if people are letting us. Again, we do smoke alarms, fire trip hazard removes. We've helped folks rearrange stuff in their closets even, and even move stuff in their cabinets. It's something simple like that. Our team has swept up a house before just to get stuff out of the way so they actually have a clear pathway out of the house because they were a fall risk. And we do a lot of durable medical equipment installation, provide instruction for a lot of folks coming out of the hospital. They don't even know how to sometimes even, check their sugar level, do their oxygen tanks. We've had folks at Boyers that weren't understanding even how to use it for the family. We have folks on hospice. We maybe work with the family under kind of understanding hospice and letting that procedure kind of happen. So we do a lot of different things within that realm. Again, we do a lot of referral and follow-up, meaning our folks are on the phone a lot. Not only are they going out to homes, they may be driving at the same time while calling a client's doctor. These are just some of the folks that we've used, like Area Agency. We use a caring closet a lot for those that need durable medical equipment and can't afford it. Caring closet is a phenomenal organization that gives free stuff away. So anything from walkers to raised toilet seats to, I don't know. I mean, the truck has been filled with different things at one point, wheelchairs and everything else. And we're also able to get stuff that folks don't need anymore. We're able to donate it back into the caring closet and help them. Do Medicare, medication assistant, or Medicaid, Medicare assistance at times. We work really closely with APS as well as Home and Community Services that provides different levels to seniors and those with disabilities on different things, whether in the hospital, whether they're doing in-home care, whether they're working on getting placed and so forth. We do a lot of advocacy referral to folks. So folks needing meals, there's Meals on Wheels. There's a couple other meal agencies in the area. Some are good. Some folks love them. Some people don't. So we look for which one's going to work for folks. We do medical transportation. We schedule PCP appointments, the MedRec, transitional care. We link people to mental health or substance abuse services, whether it's be formal treatment or even just kind of AANA type of treatment or NAMI treatment. We're able to help folks get kind of attached to those, at least start that process because it tends to be a longer road for folks. And sometimes that is more of a chronic condition. We work a lot with unhoused populations. So we have a couple different referral sources we work within them, whether it be through SHARE or Council for the Homeless. And we work also very close with the SWATCH Pathways program and their new program at the hospital called PATCH for homeless folks. And then we do a lot of community health referrals to that hub navigation for SWATCH and Pathways to really kind of look at what folks are needing and how we can connect them to more longer term solution. Again, we're not there to be a long-term solution. We can be there for quite a few months sometimes, but really we want folks not to need us or not to need 911 as often as they do. And our behavioral health co-response program, this is our one that includes a CCFR, kind of our community paramedic right now, and a CMAR mental health professional. They are, we use CMAR employees from their adult mobile crisis intervention team. So they're able to join with us and they are actually joined with us. They're at our station, they ride along, they are partners in it, and they respond to kind of alongside EMS response or a law enforcement request. They will self-dispatch themselves or go out on a call if it's being requested from the crew. They don't transport independently, although sometimes they have to help folks get to where they need to go, whether it be home or to a doctor or whatnot. They're really looking to divert emergency services if the incident is deemed to be that non-emergent so that we can kind of clear folks. If they do need to go to more appropriate services or a higher level of care, they're able to help either get folks there and so forth. Again, right now, we respond to the cities of Ridgefield, La Center, Woodland, and Battleground, and all those other CCFR Fire District 3 areas right now currently. So those emergent we talked about with folks that are really looking those, we can really assist EMS crews with patient care prior to the ALMS transport. So maybe de-escalating someone so they're able to actually get into the ambulance on their own. Assist police with verbal de-escalation, especially for mental health crisis. Connect patients with care for more long-term support and provide support advocacy for the patient subject during a crisis. This is actually, they're really good too about getting folks into more appropriate care. So maybe instead of the hospital, they're calling Rainier Springs, they're calling Lifeline Connections. They're getting that set up so the transport can be direct to there. So they don't even need to go to the hospital, especially if it's strictly an emergency, behavioral health emergency for mental health or substance abuse. They respond to overdose calls. They'll respond to all of those, especially when it comes to looking at any kind of behavioral health kind of issue, as well as some low acuity. Those non-emergent, so again, within those, they can clear police if needed. They can downgrade or cancel EMS. Again, they can provide, support for the whatever crew is going out, let them know the situation and leave it to their discretion whether or not they want to come out or if they want to clear and respond to another call. So they're able to be that backup for them, as well as arranging alternative transportation to a mental health facility. Again, that was a lot of information. Again, we kind of only had a few minutes, but I really want to just kind of put it out there of what can be done with these situations, because I know that these are new programs for fire and for EMS. Typically, we've seen a lot of co-response and a lot of different things within law enforcement programs, or we've seen a lot of social service programs go into jails and corrections, but we typically have not seen it within fire crews. So far, I mean, we've looked at some of the numbers, even of our fall calls, they have drastically decreased of those guys that are calling frequently. A lot of the frequent flyers, those multi-visited patients, the ones that call for quite a bit of different needs, we've seen a decrease in those calls within some of those folks. Even if they went from 5 calls a day to once a week, that's improvement for me, and I'm okay with that. Because folks will still have issues. These are chronic conditions that people have dealt with most of their life. And so really getting them into a place that we're able to do it. We've had some really good success stories. There's sometimes we're not able to help, unfortunately. And we do our best to try to get them connected to whatever we can. But I think it's been pretty good. And our path to really look at how we do this community wide, I think is needed. And I think within fire, we have a unique position in the community to be able to do that. And it's, I think it adds to the overall program value.
And I know we're at the end of our time, but we'll coordinate with Mark and we'll put our emails in the chat. So if you have any questions, you can reach out directly. You will see us in the field. If the follow-up team, we have had a few situations where they're at a patient's home and discover that they need transport. So wherever you're at in the county, there's a chance that you'll get dispatched, show up on scene and find them there. It'll still get a regular full EMS response with an engine medic unit for transport, but you'll see them out there. We're working to try to make it available. We've not turned down any referrals. Right now, we haven't unfortunately had the capacity to just open it wide and say, send us all of your high system utilizers. But if anyone in the county has any particularly difficult patients, a lot of those we're probably already getting because they're referred through the hospitals. But if not, certainly feel free to reach out and we'll try to help you however we can. And as we build a little bit more capacity, hopefully over the course of this year, we'll be better positioned to kind of open that door wide, county-wide for some additional support.
Yeah, I think really using these programs as just extra tools to assist in kind of the patient care is really what it's about. And so we want to be there. We're open for questions, open for feedback. Again, we'll do our best.
Thank you for the time and the opportunity.
Absolutely.
Yeah, well, thank you guys.
Thanks, gentlemen.
Thank you.
And Mark, are there questions in the chat?
There is nothing to chat.
Do you have our emails we put in there?
I'll post it after.
Okay.
So it's available for perfect kind of stuff where I'm at right now, but yeah.
Yeah, you put both Sam and mine and then
Okay.
reach out to everything.
Absolutely.
Thanks. We'll just get switched over to the other presentation, but I really appreciate you guys coming, and I really appreciate, I know for me, like throughout my career in EMS and emergency medicine, a lot of times it feels kind of like pushing a rock up a hill, and then like you go the next day and like you push the same rock up the same hill. And so this programs like this feel really hopeful because we can't fix all problems. We can't prevent all 911 calls, but we can, there is stuff that can be intervened on, and there is stuff that can help. And I think these guys are doing a great job of making that difference, which hopefully is, making the job of the field EMS provider a little bit better.
Thank you.
Okay. And Mark, any other questions in the chat?
There was a question about, is this coming to Vancouver, the city of Vancouver? And I basically responded that eventually the goal is to get it countywide.
Yeah, and I think it takes some time to figure out what exactly the needs of each community are and what the ways are to do that. And as they mentioned, there are some programs that are going into the city now, like the hospital follow-up, and the team is willing to help wherever possible. But we're trying to work with each individual agency to figure out the best way to help, the best way to work as a team. But our vision overall is that this will be a countywide program, but with participation from as many agencies as are interested. So with that, we'll use the rest of our time to do review on abdominal pain. It's just bread and butter of what we do. And so I just want to talk about thought process, a few things to keep in mind as we're taking care of these patients. Okay. it's no surprise to you, this is a huge chunk of what we do. So in terms of all the calls we run, and what we call the primary impression, fifth most common is abdominal pain, something that we see every day. And it's something that rarely needs an emergent intervention, but particularly in elderly patients can be particularly high risk. And it can be, of all the things we see, probably the most difficult to figure out, because it's like, you got this box here, you're trying to figure out what's going on. And for stroke, for neuro problems, we have the neurologic exam to figure out what's going on. For cardiac, we have the ECG to figure out what's going on. And for respiratory, we have our lung exam. But for abdominal pain, you get something out of the abdominal exam, but a lot of the clues to what's going on are in the vital signs, are in the history. And so it's taking all these clues together to try to figure out what's going on in this box. So elderly patients with abdominal pain are some of the highest risk patients that we see. So if someone over 65 with belly pain, over 50% of those end up getting hospitalized. Many are initially misdiagnosed. And overall, someone over 65 with abdominal pain presenting to the hospital, about 10% of those patients die. And so it's a higher mortality than STEMI. And it's usually much less time sensitive than STEMI, but it's a high risk chief complaint. So just like a 65-year-old complaining of chest pain has significant risk, a 65-year-old that's complaining of belly pain also has a significant risk. These are patients that when they come into the emergency department, we're almost always doing a CAT scan of the belly because there are so many risky things in a patient of that age presenting with belly pain. So these are patients that definitely benefit from a full emergency department evaluation. So learning objectives for today, we're going to fine tune your approach to abdominal pain, talk about the thought process, talk about some of the clues you want to pick up on. We'll look at specific pitfalls, a few cases that may show up as something that looks less concerning, but could be more concerning. And then we'll go into some other details about the critical nature of elderly patients with abdominal pain. Whereas for young patients with belly pain, a 25-year-old with belly pain, it is rarely something life-threatening. Someone over 65 with belly pain, that is commonly something that's really dangerous. So how do we figure out what are the key components in the history and physical for someone with belly pain? Okay. So onset is really important. That sudden onset is almost always a vascular cause. Occasionally, if you get the intestines rupturing, that'll be sudden onset. But someone was like, I was feeling fine, and then all of a sudden I had this severe belly pain. That is almost always a problem with the vessels. Getting some information about what provokes and palliates it. Does it get better with moving? Does it get better with movement? Does it get better with eating? Get worse with eating? Worse with positioning? Understanding the quality and the radiation. So if you get cut on your arm, my arm hurts right there. The belly is a lot more difficult to figure out. And where you feel the pain has to do with where the organs start when you're in the embryo. So take someone with kidney stone, they've got this pain and it starts in the flank and then it can radiate down to the testicles. That's because the testicles start in the embryo inside the abdomen. And so, and then as the testicles descend, all of that pain along the genitourinary system kind of follows along that same path. The timing of the pain can be a clue. I mean, I think the classic example of that is about 6 months ago, I saw an 18-year-old female who presented with belly pain, and she'd seen a primary care doctor for weight gain about a month prior, and talked about diet. But this belly pain was like, first it was every 5 minutes, and then it was every 4 minutes, and then it was every 3 minutes, and the nurse asked, she seems really uncomfortable. Can I get an order for some pain medicine? So well, let me just go see her. And or it's like, well, she's at least 35 weeks pregnant. And she delivered not long after that. So that's the extreme example, but understanding the timing of the pain, and we'll go with some specific complaints into how they're timed. And then risk factors are an important thing to understand what the patient might be getting. Probably the biggest risk factor for GI problems is alcohol use. Smoking and NSAIDs also set you up for GI bleeds. And then prior surgeries. Someone in general, someone who's had multiple prior surgeries is at much higher risk than someone who has never had an abdominal surgery. And then you might pick up environmental clues, like, for example, a dozen bottles of vodka that are on the floor, or the McDonald's wrapper, things like that can give you other clues as to what might be going on. So one of the things that we look for in the physical exam, serial vital signs are really important to figuring out what's going on with belly pain, and that single episode of hypotension that we often catch early in the pre-hospital setting really predicts how well these patients will do. And so if they temporarily drop, that really does matter, because then you might see them, okay, their pressure drops, you start giving them fluid, and then they do better. And then they get to the emergency department, the pressure is stable. But even just like in trauma, having had that single episode of low blood pressure is a predictor of badness. Skin signs are really helpful. Patients with abdominal pain that are cool, that are diaphoretic, definitely raise your index of suspicion. I brought this slide up here. You're like, why is there that's a sheep eye? So one of the things that can give you an important clue about how someone's doing in terms of a GI bleed is how pale they are. And particularly pulling down the eyelid and looking, you can get a pretty accurate sense of how what their hemoglobin is. And because it can be different, in different skin tones, it can be different, but looking at the conjunctiva, the lower part of the conjunctiva. So this is from an agricultural side about like when you need to deworm your sheep, because that's the biggest cause of intestinal GI bleeding in sheep is worms. That's not an issue for most of us, but you can see as you progressively lose hemoglobin, that conjunctiva gets paler and paler and paler. So that's one key clue that you can get along with the vital signs as far as what's going on, especially with a GI bleeder. Pressing on the belly can give you helpful information. And the key thing that I want to pick up on is what a surgical belly feels like. Does everyone remember hearing that term in their rotations or? Yeah, or it's having those peritoneal signs. So it's someone who's like, you've pressed on a belly and you're like, it feels soft, right? It hurts them when I press. Surgical belly is like, it is super tender. It's typically pretty tight and tense, guarded, and that is something that can really predict the pace of things, because someone with sudden severe abdominal pain and a really concerning abdominal exam, those patients almost always are going to need the operating room, and that isn't a diagnosis you need to make in the field. But if you can give in your report that this patient has rebound tenderness, has severe guarding, that's an important predictor as far as what's going on. You can tap on the belly. The one thing I would know is that you can see, we see lots of distended bellies. Someone with ascites is filled with fluid. If you tap on it, it sounds like a drum. That's probably someone who's got a lot of air in their belly. It's not a critical part of the EMS evaluation, but it's what we're trying to figure out. It's like cheap ultrasound. Pulse exam, obviously feeling for pulsatile masses in the belly, but especially with that severe sudden onset belly pain, checking pulses in the legs, because we have to think about the possibility of a AAA, and understanding, okay, person had sudden onset, severe pain, a lot of tenderness. I should check the pulses in the legs because those things can go together. And then the entrances and the exits, meaning you've all seen patients that like have that coffee ground emesis around their mouth. You don't need to do a rectal exam, but it, you'll see patients that have melena going all down their legs and all over the bed. So we'll go through now and talk about kind of lumps of problems. So vascular problems typically present with a sudden severe pain. These are the most time sensitive. Acute aortic syndromes are the great masquerader. They look like a bunch of other things. So they often present with truncal pain, so chest pain, belly pain, plus something else. My arm hurts, I have stroke symptoms, my leg went numb. It's because the aorta is the only thing that connects all that stuff. So when those go together, that should raise your index of suspicion. So any of those, you think of it, pain in here plus something else. The aorta is retroperitoneal. So peritoneal, the abdominal contents, aorta behind that. So it's pretty rare that you're going to have a ton of belly tenderness with someone who's got an acute aortic syndrome, but they're just going to have this intense. Sometimes they describe it as belly pain. Often it's described as back pain. Just reviewed a case about a month and a half ago. Someone who presented with back pain, sudden severe onset, had a but it in the pre-hospital setting sounded like typical back pain. And then as they're moving the patient over to as they're scanning the patient had a near syncopal episode in the hospital. So catching those episodes where the blood pressure drops, we're talking really important clue that something's going on. Patient ended up having a ruptured AAA. The other thing that can happen with as you get aorta, basically you get communication between the aorta and the intestines. And so also just copious amounts of bright red blood just coming out the rectum. Relatively rare, incredibly life-threatening. Another vascular problem that you can get is mesenteric ischemia. And so just like you get angina if you have coronary artery disease and you exert yourself, mesenteric ischemia is a similar process in the guts. So you eat and you get this sudden and severe abdominal pain. It tends to kind of come and go. The things that put patients at risk for that are the things that put patients at risk for having problems with their blood vessels and with clots. So atrial fibrillation, other vascular disease like coronary artery disease, peripheral vascular disease. Things that involve the digestive system are generally gradual in onset. So this is typically, say, for example, a patient with diverticulitis, common stories like, Tuesday I felt a little bit, my belly was hurting a little bit, and I got better, and then like Wednesday was a little worse, and Thursday was a little bit worse. So most life-threatening of these is the GI bleed. In the worst case scenario, we might even need to manage the airway because there's such copious bleeding. And the things that put patients at risk for that, as you mentioned earlier, smoking, alcohol, NSAIDs, and obviously being on anticoagulants means that if you do get a bleed, you're more likely to have a severe bleed. In an upper GI bleed, typically there'll be some vomiting of blood, can be bright red, it can be coffee ground, and then later on you'll develop melena. That's because as the blood goes through the intestinal tract, it mixes and turns the stool black. Blood is cathartic, so it'll tend to make poop a lot. Lower GI bleeds tend to be more that you're seeing bright red blood coming from the rectum. Pancreatitis is typically quite severe pain. People typically describe it as radiating to the back. Most pancreatitis is because of alcohol, and it's not uncommon to see an alcoholic patient who's like, I think this is my pancreatitis again. The next most common cause are gallstones. Gallstones can cause pancreatitis, and then there are a handful of causes that are rare, usually because of medications. Most patients with pancreatitis are just uncomfortable, but again, this is where vital signs become that clue. The pancreas, if you get leakage of the pancreatic juices into the belly, you can get multi-system organ failure, just like you would with severe sepsis. And again, vital signs are going to be your clue there. And acute cholecystitis, pretty common, rarely dangerous, but definitely is something that needs a surgery within 24 hours or so. So acute cholecystitis tends to be this really episodic pain, typically worse with eating. Typically starts in the epigastrium of the right upper quadrant. People often describe it as radiating to the back. The things that, and you can have pain just with gallstones, gallstones pass. That many times we'll send patients home from the emergency department if they have gallstones that cause symptoms. But if they're having any signs that the gallbladder is infected or inflamed, fever, continuous pain, those are patients that get admitted and get the gallbladder taken out on that visit. And that's typically when you get, as in this picture in the top right here, the gallstone just gets stuck and it's just not passing, and then the gallbladder gets inflamed. Chronic liver disease is something that we see fairly commonly. Most common cause is alcoholic cirrhosis. So they're what we call the stigmata of liver disease. You get the swollen belly that has these spider angiomas on it. Obviously, you don't see the cirrhosis itself. You can see it's called Kepa medusae, like the head of Medusa, kind of that snake-like collection of blood vessels, and that's because the liver gets really hard. All of the blood flow from the intestines goes through the liver, and so the blood just ends up backing up. And then that's why you get ascites, because essentially you think about like a garden hose that you're just plugging, just the fluid just tends to leaks out, leaks into the belly. Obviously, in men, you can see gynecomastia. Well, people can get yellowed sclera. They can get some redness on the hand. And then they tend to be you tend to be more likely to see bruising. I think they have this fairly distinctive when they get, so if your liver is not functioning well, the toxins that it normally clears can build up, and that can cause encephalopathy. The thing that's really distinctive about that is what's called asterixis. And so you ask the patient to hold their hands up and they flap like this. In a patient that's unconscious, you can just kind of hold their hand like this and it'll tend to flap against. There was a time when people thought you could figure that out by measuring the ammonia level. We know that ammonia is a pretty unreliable indicator of that, so it's not a recommended test anymore. But it's really that clinical diagnosis. It's someone who's got chronic liver disease, and then they just gradually get more and more confused. The medicine that people take for that, does anyone recall what that medicine is called?
Lactulose.
Yeah, exactly, lactulose. So white milky stuff makes you poop. So the way that a doctor figures out if like they're doing the right thing to help clear the liver toxins out is normally a patient will have a goal like, okay, well, if I'm pooping 2 to 3 times a day, then they know that they're clearing that stuff out. It is not uncommon for someone to either forget to take that medicine, or you get a little goofy and then you forget to take it and then you get really goofy. So that's a really key piece of the history. Are they on lactulose? Have they been taking it? Something that some often family can help with. And with liver disease, for multiple reasons, it becomes harder for your blood to clot. So they're at risk for bleeds, both like head bleeds when they fall, GI bleeds. when you see someone go into acute liver failure, then that's someone who over the course of a few days goes from being relatively normal to really, really jaundiced. You know, you walk in the room, they look super yellow. They'll often describe clay-colored stools. That's because the bile is what gives the stool its brown color. And so if the bile gets blocked, can be from a duct obstruction, it can be from liver failure, then you'll just have these kind of ashen clay colored stools. And they tend to get really yellow in the eyes. Often you'll see it before you see it in the eyes. If you ask the patient to lift their tongue up, you'll see it kind of on the underside of the tongue. You'll see some yellow there. And that tends to, the patients with chronic liver disease that, progress over months and years, but acute liver failure is progressing over, over the course of a few days. Another cause that we can see for that is Tylenol ingestion. It was missed initially, and they don't have pain. But then if it goes untreated, then in a couple of days later, then they'll go into acute liver failure. Bowel obstruction is something that we see fairly commonly. This is where those previous surgeries are the biggest risk factor. So you'll look at someone's belly and they've got all these zippers on it. Or they'll tell you, man, I get a lot of bowel obstructions. This feels like my previous bowel obstruction. And to be clear, that's not, patients will often confuse that with like, I'm really constipated, but it's, constipation is like a lot of stool building up, but everything's making it through. A bowel obstruction, you think of it almost like a water balloon that's got a twist in it and stuff is just not making it through. And so they'll often be vomiting, they won't have stool output. And then at some point they'll even stop passing gas if they've got a full obstruction. You can smell it, like you walk in the room and like the breath smells like feces. And then they tend to be really distended. And unlike a liver patient that's filled with fluid, they'll tend to be filled with air because nothing's making it through. We also, this is probably the one digestive problem that presents relatively suddenly, and that's a perforated viscus, meaning basically a hollow organ ruptured, stomach, intestines, and they will have this severe pain. So it's typically preceded by several days of having some pain, and then all of a sudden it got severe. This picture is of a chest x-ray where you can see air under the diaphragm, and that's how we diagnose these. And so not uncommon on the patient's left, you see the stomach and you see that air, but in this x-ray on the patient's right, you've got that black line under the diaphragm, and that means that there's free air in the belly. You've got someone with severe pain and an x-ray like this, that's enough for the surgeon to take them to the operating room, is they'll need to open up the belly, figure out what ruptured. The key EMS finding is just that sudden severe pain and that really concerning abdominal exam. Diverticulitis is also quite common. Diverticulitis is really rare in younger people, becomes more common as we get older. And so it's essentially a little pocket coming off usually the large intestine, and you get some inflammation there. And it can be like a seed or a nut, something that starts to inflame it, and then they'll get essentially a small pocket of pus there. We diagnose it with CT typically, and we put patients on antibiotics. Most patients get better. 95% of patients get better with a course of antibiotics, but then there's a chunk, you treat them with antibiotics for a few days and then they get worse. And so they can develop perforation or an abscess. So this is a patient where like, oh, I was seen in the emergency department 3 days ago. They said I was okay, but it was diverticulitis. Now it got worse. It's not getting better. those patients we need to see again. Often they need a repeat CAT scan, and typically they'll get admitted at that point. Again, it's only about 5% of patients with diverticulitis, but it is something that happens. Appendicitis is one of the things that can affect younger people as well. We have some time to make this diagnosis. In general, we're trying to figure it out within the first 72 hours. It often takes serial exams to figure it out. The classic presentation is that someone gets some pretty generalized pain, and it can start, I've seen it start on the left, start in the epigastrium, pretty generalized pain that over the course of a day or two localizes to the right lower quadrant, and they'll tend to be pretty focally tender in the right lower quadrant. But some people have appendix in slightly different locations, so it can show up in different locations. Something we have time to figure out, but we definitely want to figure out, because if you treat it early on with antibiotics and surgery, they're typically out of the hospital in 24 hours. If it does rupture, which can happen at about 72 hours of symptoms, then they typically need like a week in the hospital on antibiotics. It's a much longer course. Inflammatory bowel disease, Crohn's and ulcerative colitis. Having those diseases puts you at risk for abscesses, puts you at risk for bowel obstruction. And these are patients that are often on, these are autoimmune diseases, so they're often on strong immunosuppressants. So they're at risk for other infections because they're on their immunosuppressing medications. Something that didn't exist, or at least wasn't aware of when I started my career in EMS and emergency medicine, is cannabinoid hyperemesis syndrome. It's not dangerous, but it can be really debilitating and frustrating. We typically see it in patients who use marijuana daily, and they typically need to do it for at least a year, like heavy use for a year. Now, some people do, use heavily for many years and never develop it, but the marijuana that we have now coming from the dispensaries is more concentrated, much stronger than the ditchweed that was around when most of us were kids. And so people often will start taking it for nausea. They have issues with nausea, or they just take it because they like it. But then after an extended period of use, then it can trigger this paradoxical response where it causes this profound nausea and vomiting. They can get pretty dehydrated. They tend to have this really kind of intense episodic pain, but their belly feels pretty soft. And the one thing that's really distinctive about this is that people say it gets better when I get in a hot shower. And no one really understands why that is, but there's something about triggering those heat receptors that tends to make it better. One of the treatments for it is actually putting capsaicin, basically pepper, with the thing that makes pepper hot on the skin, and that tends to help people with it as well. So it's just something to, one other thing you can gather in the history that can give a clue as to what's going on. And we may not be aware, in the emergency department that like walked into the house and like all of a sudden this is intense odor of marijuana. Foreign body is often something that we can let pass on their own, but we want to sort out what it is. And there are a small number of items that are potentially dangerous. So one magnet, not a problem. Two magnets, a problem, because they tend to adhere to each other, and then they can create a fistula, an opening between the intestines, and you can have intestinal contents leak out. So getting that history that there were two magnets that were ingested, much more dangerous than a single one. And it's the ones we particularly worry about are the rare earth magnets, neodymium. They tend to be strong, they tend to be small, and for a kid, they look like about the size of a candy. Button batteries, and again, this is typically a toddler ingestion. But those, when they get exposed to the stomach acid, they open and then release a lot of acid into the stomach. So we try to get those out as soon as we can. So that's an important piece of the history. Many button batteries now, they've added a bitter taste to them. But because people have so many devices that use these, they're very common in watches, other electronic devices. They're definitely something that can be ingested. And then obviously sharp objects are much riskier, razor blades, things like that. So we making a decision about whether to go after it. We figure out where it is, how sharp it is, how long it is, whether it could safely pass on its own. But there are some people who, say someone swallows one magnet, then the risk of going after it would be greater when they send them home and let them, let them pass things on their own, but tell them to come back if they start to have pain. Okay. We'll talk about GU problems. Okay. So probably the most common of these that we see is renal colic. It tends to be very painful, rarely dangerous, unless there's an infection. Patients that have a urinary infection with a kidney stone need a procedure, and they tend to get septic fast. It's essentially pus under pressure that unless you drain that obstruction, they will get pretty sick fast. The thing to most think about if you're thinking about renal colic, especially in an older person, remember a AAA can present in the same way. You can have this really intense pain. It's in the back. A AAA can even cause blood in the urine if it dissects down to the renal arteries. So the thing in the back of my mind is I was seeing someone like, I think this is probably renal colic, but how do I know it's not a AAA? How can I sort that out? These patients typically want to go because they're so uncomfortable. Okay. Pyelonephritis is kidney infection. So it typically starts with a urinary tract infection, some dysuria, some pain with urination, and then it travels to the upper intestinal, to the upper GU tract. And so the clues that that's happening, they'll tend to have flank pain, they'll tend to have fever. Often they'll be vomiting as they feel really miserable. Elderly, debilitated patients tend to get quite sick with this, but even some young and healthy patients, and it's more common in females than males, can get relatively sick with this. Vital signs are the clue there. Okay. And then urinary tract infection is something that we think about and we talk about a lot. There's been a significant change, certainly since the start of my career, in terms of how we think about it and when we decide to treat it. So we don't diagnose a urinary tract infection by foul smell, by cloudy urine, by confusion in an elderly person. To make the diagnosis, you need urinary symptoms. So it hurts to pee, I'm peeing more frequently, I've got some pain here, and then a UA that matches with it. Now, are there confusing cases where you've got someone who's altered and you need to fully work them up? And sometimes the only infection is a urine infection? Yes, but in general, just that finding of like foul smell of those other things, we won't make a diagnosis of urinary tract infection. And one of the reasons for that is, one, you look at elderly females, 10% have bacteria in the urine without any symptoms. And what we run into is we try to treat all of these, we get these patients with these multi-drug resistant organisms. And they can, when they do get a urinary tract infection, meaning bacteria in the urine that's causing symptoms, then they can be really difficult to treat. So we just try to be judicious with how we use antibiotics in those cases. Okay. Acute renal failure is typically painless. But the things that you'll see is confusion. So this can be a patient who's like, oh, he was vomiting a lot and he was just in bed and wasn't really drinking much. And then he just gradually got more confused. The big thing to think about is that they can, so kidneys clear potassium. These patients can get hyperkalemic. Think about hyperkalemia, think about an EKG in a patient not urinating, dehydrated, getting confused. That can be a patient with acute renal failure. Yeah, the other time that we often see that are dialysis patient, well, it's not so much acute renal failure, but hyperkalemia dialysis patient that misses dialysis. Okay. Corneas gangrene is necrotizing fasciitis of the groin. And the reason I bring this up is that, you know, we don't expect you to do rectal exams, full GU exams in the field, but this is something where taking a quick peek can really alter the patient's trajectory. It's most common in patients that are immunocompromised. I'd say the thing that's most common is diabetes. And occasionally patients have pain, but more often it's not super painful. And like, we don't find it until like we get them naked, and then all of a sudden, like, there's this black necrotic stuff in the groin. I had a patient who we didn't find it until like we're getting ready. We're like, I can't figure out what's making her so sick. Let's do a catheter to get some urine and like look in that area. And it's like this purple spot. And she ended up, getting debrided like all the way up to here, like it just had dead necrotic tissue. It's this polymicrobial infection. Essentially, it's flesh-eating bacteria. So just think if you got a diabetic patient, say it can't figure out why, just think about taking a look if you're in a situation where you can safely do that. Testicular torsion is when the testicle gets twisted and there's no blood flow to the testicle. So there are two peaks for that. It can happen in neonates, and then boys around the time of puberty. It can be particularly difficult to figure out in neonates, but it's something like the fussy child or the vomiting child, typically in the first year of life. Those are patients we like to check out, and definitely we do a testicular exam on those patients. Tends to be sudden onset, tends to be severe. There can often be vomiting with that. And with the diagnosis, thymus testicle, we try to make this diagnosis in the first, we'll try to get to the patient to surgery in the first 6 hours. After 6 hours of symptoms, the patient's at risk for losing the testicle. When the urologist fix this, they will tack one testicle down, and then while they're in there, they tack the other one down as well. So once someone's had a surgery for this, it's very rare for it to happen again. Okay. Same thing can happen to the ovary, and this can be a difficult diagnosis. It's typically that sudden severe pain. It can be intermittent. Risk factors are anything that make the ovary bigger. So polycystic ovarian syndrome, history of ovarian cysts, was relatively rare. But if that cyst ruptured and bleeds, these patients can be hemodynamically unstable. Again, vital signs are your clue. And then the most dangerous gynecologic emergency is an ectopic pregnancy, something we have to think about in any woman of childbearing age with abdominal pain. And the thing to note for the pre-hospital treatment of this is one of the rare things where you get blood in the belly, and like a trauma patient gets blood in the belly, they tend to get really tachycardic. These patients often get really bradycardic. So it'll be hypotensive and bradycardic. No, to my knowledge, no one knows exactly why, but it's something to think about. Woman in childbearing age, hypotension, bradycardia, belly pain. So to wrap up, a few take-home points. Abdominal pain is common. The diagnosis is really difficult. We want to be a team between the pre-hospital setting and the emergency department making the diagnosis. And so picking up these clues in the environment, in the serial vital signs, really critical to helping to make the diagnosis. And then elderly patients with abdominal pain have high mortality, and we should be recommending emergency department evaluation for those patients. Questions for me? Any questions online?
No.
Okay. I really appreciate your attention. Definitely want the feedback on how this hybrid format works. And I've got this QR code that you can scan, give feedback. We'll put the link in the chat as well, so you can do that. But with that, no, thank you very much. Have a good rest of your day.
Thanks for coming. Well, I'll let Seneca know. So he knows what you get for here.